Bismillahirrahmanirrahim. Dear viewers, you are watching me. This is me, Zahor Islam, and today I will teach you about the nursing implications of anti-tubercular drugs. As we have already talked about the drug use in the treatment of tuberculosis or anti-tubercular drugs and its first line therapy and second line therapy in detail. But today the topic is related with nursing care and nursing implication of anti-tubercular drugs. Okay, now let's come to the major topics. So as we know that before clearing the concept of nursing implication, we will have to know about the anti-tubercular drugs. Now, what are anti-tubercular drugs? So those drugs which are used in the treatment are against tuberculosis. As we know that tuberculosis, it is a bacterial infection which is caused by mycobacterium that is called tuberculosis. Anti-tubercular drugs treat all form of mycobacteriums. Mycobacterium, it was for the first time discovered by Robert Koch in 1882. Let's see here, anti-tubercular drugs, mycobacterium infection, these are the common infection sites. This mycobacterium can directly attack on different sites, so that maybe you can see here in the slides. So the primary site, that is lung, or you can say tuberculosis. One is pulmonary tuberculosis, the second one is extrapulmonary tuberculosis. So in pulmonary tuberculosis, this mycobacterium can directly infect the lungs, while in extrapulmonary tuberculosis, so it can infect the other organs of the body rather than lungs. These are the common infection sites. So the primary site, that is lung. So its initial attack is on the lung, that is called pulmonary tuberculosis, and then brain, and then bone, and then liver, and then kidney. It means that rather than lungs, other organs of the bodies may be infected due to their species, that is called mycobacterium. Now let's see here, aerobic bacillus. Aerobic bacillus, they are fast from the infected humans, cows, bovines, and birds, avian. So they are much less common. Anti-tubercular drugs, mycobacterium infection, tubercle bacilli, they are conveyed by droplets. This is the main mode of transmission. So how this bacterium is transmitted through with the help of droplets, air droplets, and these droplets are expelled by coughing or sneezing, and then can enter into the body by inhalation. Tubercle bacilli is then passed to the other body organs via blood and lymphatic systems. Tubercle bacilli may become dormant or wall up by the calcified or fibrous tissue. Now come toward the anti-tubercular drugs, tuberculosis, the basic pathophysiology. That how, what is the basic compensatory mechanism through which this tuberculosis can occurs. Mycobacterium tuberculosis is caused by gram-positive acid fast bacillus bacteria. Tuberculosis can be spread from person to person via airborne droplets, which I have already mentioned in the previous lectures. It may be spread through coughing, sneezing, speaking, and dispersed organism can be inhaled. Not highly infectious, required close, frequent, and prolonged exposure. So it cannot be spread by hand, books, glasses, dishes, and other pomates. It means that this mycobacterium cannot be transmitted through these sources, like shaking hands, by books, glasses, dishes, and other pomates. Anti-tubercular drugs, tuberculosis, this is the clinical manifestations. Look at here. In early stages of tuberculosis, a patient or a person is free of symptoms, many cases they are found incidentally. Now look at the systemic overview, the systemic manifestations. So maybe in the form of fatigue, malaise, anorexia, weight loss, low-grade fever, night sweats. Weight loss occurs especially in the last stage. These are the characteristics, the basic clinical signs and symptoms in the form of cough, frequent and produced mucoids or mucopurulent sputums, dull or tight chest pains. While in some cases there is acute high fever, chest chills and general flu-like symptoms like pleuritic pains and productive cough. Especially an HIV patient with tuberculosis, having fever, cough and weight loss may be occur, and cystic kidney pneumonia may be occur. This is the clinical manifestation. So anti-tubercular drugs, tuberculosis, this is the diagnostic study. So you can see here tuberculin skin testing that is performs. Let's suppose if this reaction is positive, reaction is can be occurred in 2 to 12 weeks after the initial infection. That is called PPD, purified protein derivatives. You know, this is used actually. These are the diagnostic tests which is usually performed for the tuberculosis, and they are used to detect the delayed hypersensitivity response. Two-step testing, healthcare workers, they perform 5 mm, that is you can say greater than n durations, especially in immunosuppressant patients, those patients who have weak immune systems, and it may be 10 mm injections that is greater than, that is at risk, especially in population and healthcare workers, while 15 mm that is you can say greater than, there is low risk peoples. So I mean that these are the different diagnostic tools or diagnostic technique through which we can perform tuberculin skin testing in order to know the tuberculins. The chest X-ray used in conjunction with the skin testing, and multinodular lymph nodes involvement with cavitations in the upper lobes of the lungs. Calcification may be occurred within several years after infections. Bacteriological studies, sputums may be this mycobacterium is found in the sputum of the patient in the gastric washings. Early morning specimen for acid bacillus in 3 consecutive culture on different days. CSF, cerebrospinal fluid are first from an absence. So this is bacteriological studies, or you can say pathogenic study. Now come toward the medical, how we can manage this case, medical management for the anti-tubercular drugs. So it may be treated as output, depends on the debility and the severity of the symptoms. So depend upon on the severity of the symptoms of the patients. This is the mainstay of treatment, drug therapy for active disease. Look at here, these are the drugs, 5 primary drugs, as we have already discussed, and first line therapy, anti-tubercular, first line therapy of anti-tubercular drugs. So that is 5 primary drugs which are isoniazid, can be represented by capital letter INH. These are the primary drug used. So first primary drugs, so that is that include isoniazid, rifampicin, pyrazinamide, streptomycin, ethambutol. While the combination 4 drug therapy is HIN, especially in HIV patient which cannot take rifampicins or rifampicin, so it can interfere with the antiretroviral drug effectiveness. Now come toward the anti-tubercular drugs, second line drugs. Second line drugs which I have already discussed in detail, that is capreomycin and cycloserine and ethanamides and kanamycins, para-aminosalicylic acids, amikacin sulfate, levofloxacin, ofloxacin, and many more. So if you remember, so I have already discussed about all these things in detail in lecture number 51 up to 53, so you can study these lectures in detail. anti-tubercular drug therapy considerations. So perform the drug susceptibility testing on the first mycobacterium species that is isolated from a patient specimen to prevent the development of MD or TB, multi-drug resistance TB. Even before the results of susceptibility tests they are known, begin as a regimes with multiple anti-tubercular drugs, and then you should adjust the drug regimes once the result of susceptibility testing they are known. Monitor the patient compliance closely during therapy and problem with successful therapy, patient non-adherence to the drug therapy, and increase the incidence of drug resistance. Now look at here the anti-tubercular therapy. The effectiveness depend upon the type of infection. The effectiveness also depend upon the adequate dosing, the sufficient duration of treatment, and drug compliance. Either the patient is properly follow the medication of the physician or not, the selection of an effective drug combination. So it also come under the category of effectiveness. And especially now we are also facing some problems in anti-tubercular therapy. There may be chances of drug resistance organisms. So there are some candidates and some patients who are resistant with certain drugs. So there may be chance of drug resistance related problems with organisms and drug toxicity, as well as the patient non-compliance. That the patient couldn't follow the medication properly, or the multi-drug resistance TB-MDR. Anti-tubercular drugs, isoniazid INH, you know that this is a drug of choice for tuberculosis. Resistant strains of mycobacterium emerging, their metabolizing in the liver through the process of acetylation, and watch for slow acetylators. Use alone or in a combination with other drugs. It is used for the prophylaxis or treatment of TB. These are the various adverse effects which are reported by the different literature review. So as we know that isoniazid may cause peripheral neuritis and hepatotoxicity. Ethambutol may cause retrobulbar neuritis and blindness may be occur, while rifampicin have reported hepatitis and discoloration of urine and stool. These are the adverse effects which are reported after recommendation after the use of these agents. So there may be chances of adverse effect due to overdosings. Anti-tubercular drugs nursing implications. Inshallah, in my next lectures I will discuss about the basic anti-tubercular drugs nursing implications, that how the nurse is responsible to take much care about the patient as well as the drug. Inshallah it will be discussed. Thank you so much for watching my lecture, and inshallah if you have any question regarding my lecture, so you can directly contact me through my email. Thank you.